So this is our last session, as we said, before our lunch break. So for this appetizing discussion, we have a wonderful esteemed panelist, a great national representation. We have Dr. Lee Schwartzberg from renowned cancer center. We have Dr. Matthew Getz and Dr. Ruta Rao. So let's start with this. And Dr. Matani, if you can join us as well when you're back. Let's start with a case. So we're going to talk about targeted therapies, especially in this era of precision medicine. And we'll walk through this engineered case as well and think about various scenarios that we might face in clinic when we are seeing these patients and treating them. So we have a 60-year-old woman who's postmenopausal, initially presented with a 3-centimeter tumor that was grade 2, node negative, ER positive, HER2 negative. And this is actually, perimenopausal, looks like there's a typo there. She underwent a lumpectomy, sentinel lymph node biopsy, and an oncotype score that was done was 23. She had adjuvant chemotherapy with docetaxel and cyclophosphamide for 4 cycles, followed by local regional radiation, was started on tamoxifen for 2 years and then switched over to anastrozole. Unfortunately developed metastatic relapse in the bone and small volume mediastinal lymph nodes 3 years after completing her anastrozole. So tamoxifen, anastrozole, and 3 years after that developed metastatic disease. So let me ask a question to the panel here, and maybe I'll kick off with you, Ruta. What is the role of metastatic biopsy in such a case?
So I think the standard answer would be that if the tissue is able to be biopsied, we should biopsy it. There's a number of reasons, like Dr. Matani said earlier, the tissue is the issue, so it's always good to know. You know, once in a while you can find a patient who has a different tumor type with that metastatic biopsy, but even if it's breast cancer, it's very important to retest the receptors. We know that there can be some heterogeneity of the receptors from the primary tumor to the metastatic site. And also, I think you get into this with your next question, we can do some more precise testing of tumor mutations.
Yeah, so maybe Matt will go with first name basis here. Matt, if you can walk us through the role for next generation sequencing, and when you're thinking about that, how important it is, when do you actually do it? Do you prefer the primary tissue? Do you think about the metastatic tissue? Or do you resort to liquid biopsies? If you can walk us through that.
Yeah, these are really important questions. Obviously, in the setting of first-line recurrence for ER positive, HER2 negative breast cancer, where CDK4/6 inhibitors are a standard of care, we don't, as of yet, have data that would suggest that results from an NGS panel would change our management. So patients are still going to be treated with, in this case, a CDK4/6 inhibitor along with an aromatase inhibitor. Of course, one of the questions that comes up is, well, if you have an ESR1 mutation, would that change your choice of therapy? And again, we don't have data as of yet. There is certainly important that we do have data with regard to germline testing. So at some point, of course, this patient could potentially be eligible for a PARP inhibitor should she have evidence for a germline BRCA mutation. And in fact, one of the very provocative studies that's going to be coming forward in the future is actually to look at the role of next generation PARP inhibitors along with CDK4/6 inhibitors, or in place of a CDK4/6 inhibitor, actually along with CDK4/6 inhibitor in the first line setting. But as of right now, I think we can confidently say that a CDK4/6 based therapy would be the standard of care, and our NGS testing would not necessarily inform. I do think that one of the questions that comes up, and that is, well, would it be nice to have it, because then we could look at clonal variation over time. I like to do that, but is it necessarily standard of care? I would say probably not standard of care.
Reshma, would you like to share your practice? When do you consider doing it, and what modality do you use, tissue or plasma?
Yeah, so I think that for patients that don't have tissue available, circulating tumor DNA is really convenient because you don't have to put a patient through an additional biopsy. In a patient who first was diagnosed with recurrent disease, we don't often see ESR1 mutations at initial presentation in the adjuvant setting, so it's something that we see more frequently after exposure to an AI. And I think, the other issue that's practical in terms of metastatic biopsies is many of our patients are recurring in bone only, and there are some challenges with regards to bone biopsies.
So excellent points that both you and Matt brought up about clonality and ESR1 mutations not being detected in the first line. So I think, say if it was a patient where we would think about PIK3CA mutations, and we'll talk about them as well, those are mostly truncal and clonal mutations. So if you detected them in the primary tumor, you detected them at the time of initial metastatic biopsy or at a later time point, majority of them will be clonal and truncal, so it wouldn't make a difference where you identified them from. There are some acquired, but we don't know the relevance of those really at this point. In contrast, when we think about ESR1 mutations, they are mostly subclonal, and they are being developed under the selective pressure of adjuvant aromatase inhibitors, or in the metastatic setting actually with aromatase inhibitors. So that's where maybe plasma-based assays are helpful in identifying them, and that's why the prevalence is higher in the circulating tumor DNA for ESR1 mutations compared to what we detect in tissue. So excellent points. At this point, seems like the panel is convinced, because first-line therapies is CDK4/6, the most important time to think about next-generation sequencing and even germline testing for that matter, you want to know those results, would be post-progression. So what would you do for this patient here at Ruta then?
I think the standard of care for this patient would be a CDK4/6 inhibitor with endocrine therapy. And that brings us really to this slide, which shows a summary of the results of the pivotal CDK4/6 inhibitor trials. And I'll just point out a few points here. If you look at Paloma 2, Mona Lisa 2, Mona Lisa 7, and Monarch 3, these are the first-line CDK4/6 inhibitor with endocrine therapy trials. And you can see that the hazard ratio for all 4 of these trials are essentially identical. And if you had looked at the Kaplan-Meier curves, they're really overlying each other. Where we're starting to see a little bit of a difference now is in the overall survival. And we see that Mona Lisa 2 and 7 have shown overall survival benefits. We did not see that in Paloma 2, and in Monarch 3, it was not seen at the interim analysis 2. So this really brings up the question, why was there no overall survival benefit in Paloma 2? Is this really an overall survival benefit, but just that the study was negative? That's one thought. And we know that this trial was underpowered for the survival endpoint. The survival outcomes were outperformed the expectations in the statistical plan. There was also a high rate of crossover on the study. The true rates were unknown, but they may be higher than what was documented as 12% and 27% in each arm, given the missing follow-up data. We also know that there's significant missing follow-up data that's imbalanced in these arms. For Paloma 2, it was 13% in the treatment arm versus 21% in the placebo arm. And it's likely there's also a difference in what was the definition of disease-free interval between the Paloma 2 and the Mona Lisa 2 trials. So there is additional data to suggest that it's really just a trial issue that overall survival was not seen. If we go back to the slide before this, I showed you that there's identical PFS data with the other agents. And if we reference Neil's talk from earlier this morning, we know that there's real world data for palbociclib that suggests an overall survival benefit. The combined analysis of Paloma 1 and Paloma 2 shows an overall survival benefit if the disease-free interval is greater than 12 months. The other thought is that, is there really no survival benefit because there's differences in CDK4/6 inhibitors? All inhibit the CDK4/6 complexes, but ribociclib and abemaciclib are 4 and 5 times more selective towards CDK4 over CDK6. And where we're starting to see a difference in the CDK4/6 inhibitors is in the early adjuvant setting. As we talked about in the previous case discussion, we do now have an approval for abemaciclib in the early stage breast cancer setting, whereas the palbociclib trials have not shown a benefit, and we're still waiting to see ribociclib's performance in the early stage setting.
So let me just take a moment and ask the panel if your practices have been impacted with these data sets that we have. So Paloma 2 was presented at ASCO, and Lee, I might start with you. Have your practices changed? What did you do before? Did it matter what CDK4/6 inhibitor you used, and has that changed now?
Well, I think we have to look at the toxicities of the CDK4/6 inhibitors when we're making a decision for patients. And as we talked about in the last panel about the use of, in that case, abemaciclib in the adjuvant setting, there are different toxicities, and abemaciclib, of course, has diarrhea as the major toxicity. So for a patient that had an underlying GI problem or had diarrhea from prior therapy or so forth, you might not want to use that. We see a differential in terms of the toxicities for all the drugs and also the way that they're given. So I think it's an individual patient decision on which drug we can use, and I don't think it has changed appreciably with the new data that we've seen.
What about you, Matt? Comments on that?
I think it has changed for me, and you know, I do think the slides that were presented here are really quite important, and you know, there's certainly differences you go across the studies. You know, when I present it to patients, I just say, you know, when I tell them the data that ribociclib has consistently improved survival, palbociclib has consistently not, but we're not quite sure. They just say to me, you know what, it's not a hard decision for me, and they choose ribociclib or other CDK4/6 inhibitor. So my view is that you have to look at the totality of the data. I think that, you know, palbociclib provides a large PFS advantage, but what's interesting is that it has not translated into survival advantage, and so I think the best way to really follow up to that is to look at the drug in the adjuvant setting, and I think the important of it, when you look at a drug in the adjuvant setting, and what happens when you stop the drug, because you take it for a short period of time, and if the benefit that you see while you're taking the drug is not translated into an overall, in this case, IDFS advantage, that tells me that, and so the way I view the data right now is it's almost as if the data in the adjuvant setting are mirroring what we're seeing in the metastatic setting. So that being said, I have patients that I still treat with palbociclib, and I'm not taking the patients that are on palbociclib and switching them off. I think it's just one of those things that as we go forward and as I tell patients about this, because I want them to be involved in it, obviously I want them to see the data, but they're looking at the consistency of the survival data, and they're saying, you know, I think that's what I want to do.
Reshma?
Well, I would just add that I think, you know, in the absence of any large comparative trial comparing these three agents, which is not likely to happen, the data we have the data, it is what it is, but also we have our personal experience, and I think that also factors in substantially for all of us. You know, we're here in South Florida where a lot of our patients are elderly, they're on multiple medications, there may be issues with, you know, coming to the clinic frequently for additional monitoring, those things factor in. So as Lee mentioned, the toxicity profiles certainly do factor in. I will say that in a premenopausal patient where I think that we have the bulk of the data with ribociclib, I would definitely look in a premenopausal patient to go that route. But in my practice, overall, I really haven't changed.
Okay, thank you for sharing that. So for this patient, we treated her with first-line letrozole and ribociclib and zoledronic acid every 3 months. She had an initial response, which was followed by clinical, radiographic, and biochemical progression after 13 months. She developed new liver metastases, maintained a great performance status with a normal hepatic function. We did germline testing at this point, which didn't reveal the BRCA mutation. She had the liver biopsy that did confirm the metastatic adenocarcinoma that remains ER positive. It was PR negative, HER2 was 2+ and non-amplified. And next generation sequencing that was performed did reveal 2 PIK3CA mutations, one in the kinase domain 1047R, another one also in the kinase domain 1043V, at a decent amount of variable allele frequency here, which was 33% and 20%. There were other alterations, including P53 mutation and NF1 splice site variation, and an ERBB2 was also checked, which was non-amplified, matching what we saw with immunohistochemistry. The microsatellite status was stable, and the tumor mutation burden was low at 2.7 mutations per megabase. So maybe I'll start off with you, Matt, here, and maybe if you could comment on which of these variants are clinically actionable. Maybe I can go back here on the slide just so that you can comment on that.
Yeah, great question. So it's clear that the PIK3CA alteration is actionable. The question, of course, is which PIK3CA alteration, the H10. If you could go back to the other one, so I don't say a typo. H1047R is the one we typically think about. P53 mutation in this situation is not necessarily actionable, although it certainly raises our concern because it would suggest that we have a tumor that perhaps is a bit more aggressive. We know that from a number of different studies. And additionally, the NF1 splice site alteration, there's been a lot of work on this in the recent years by Matt Ellis, demonstrating that NF1 alterations are associated with a worse prognosis. So I have a bit concern about this patient, about just this panel here, the presence of the P53 alteration, the presence of the NF1 alteration, and also, when we look at the duration, as I recall, this was 13 months, is that right? Mm-hmm. And we know from a number of different studies that the duration that you're on the CDK4/6 inhibitor is obviously very important as well. I almost like to think of it this way: is that we typically in the past would say somebody had primary endocrine resistance in the metastatic setting if they progressed on single agent monotherapy within 6 months. There is not a new definition of what endocrine resistance to CDK4/6 inhibitors are, but if we think about where the median is, which is about 24 months, 13 months is a bit concerning. So I'm concerned overall at this patient in terms of how she's going to do.
Thank you. So Lee, maybe you could comment on what would be the optimal therapy in your mind for this particular patient. Would you offer them a PI3K inhibitor? We are going to hear about the data that was presented at San Antonio from Capitello. Would you offer an AKT inhibitor? Would you consider mTOR inhibitor? Would you do fulvestrant with CDK4/6 inhibitor? Would you consider an oral SERD? We have data for that as well. And maybe also comment on, do you think there is a significance that this patient had 2 PIK3CA mutations, or what we call in this case double PIK3CA variants? And would that make you think differently?
So here we see that the NGS analysis really does help us in terms of making decisions for the next lines of therapy. And I think the idea that even in our question we have multiple choices just reflects the fact that after first-line therapy with CDK4/6 and endocrine therapy, there really are a number of other choices, and it's becoming increasingly difficult, perhaps, to make that decision. We don't yet have the oral SERD or the AKT inhibitor in the clinic, but we may have both of those available in the very near future. This is wonderful for patients because, as we talked about, we're really interested in increasing their amount of time on endocrine therapy and before they have to start chemotherapy, which ultimately is something that almost all patients have to get to. So we want to use therapies that are hopefully less toxic and also have a meaningful clinical impact. So we really have a number of choices here. In my opinion, I think, in fact, all of these, assuming those two are approved, potentially could be a next option of therapy, and we don't have any sequencing data, but we do have data on trials after a particular CDK4/6 inhibitor, and I think we now have data on for a patient who has a PI3 kinase inhibitor, as we'll see from the SOLO-1 data and the BELIEVE series of data, that there is an impact for using combination therapy with a PI3 kinase inhibitor and endocrine therapy, and that would be my choice. The significance of the double PI3 kinase variant remains to be established. However, there is emerging data that having a double mutation, which is not an uncommon phenomenon, occurs most commonly in breast cancer and in endometrial cancer and other GYN cancers, is not uncommon. You might see that in 10 or 20%. Remember that a PIK3CA mutation occurs in about 30 to 40% of metastatic HR-positive, HER2-negative breast cancer. And there may be better benefit, we have some data we'll show, that's just emerged and just been published on a study from a different PI3 kinase inhibitor, which suggests that that might be the case. So I think in this case, the best data we have would be to do that. Now, you certainly could consider, we have data now for changing CDK4/6 inhibitor and changing fulvestrant, the MAINTAIN study, which was presented, the phase 2 trial. So that's another option as well. And mTOR inhibitor remains a standard that also, particularly with everolimus and fulvestrant or exemestane, would be another option as well.
Thank you, thank you. So what would you pick for this patient? So clearly there are many options. We don't have the best optimal sequencing.
So I would pick alpelisib and fulvestrant for this patient.
And so one of the last questions that we have on this slide, and also came in from the audience along those lines, so when do you think about doing recurrent next generation sequencing? Do you do that in your practice? Do you use circulating tumor DNA, if you will, for every progression, or when do you definitely use it? Could you comment on that? Maybe Matt, Lee, anyone?
Yeah, I don't think there's a standard yet, and this is an area of active investigation for sure. And NGS testing or liquid biopsy, we're not going to get into monitoring residual disease, particularly in this panel, but I think we're all excited about the potential for patients who have a deep response about looking at that. And so I think liquid biopsy will become increasingly important in the future. There are also ways to look at circulating tumor cells and look at immunohistochemical or immunofluorescent approach to protein expression as well. So the technology is advancing in a way that we can use this, either repeat tissue testing, which becomes problematic in patients to continue to do testing, particularly of visceral biopsies, but liquid biopsy will be used in the future. I do think it's not quite ready for prime time yet, because as you mentioned, we have truncal mutations and then we see subclonal mutations, and we're not really sure, at least in breast cancer yet, what the meaning is of treating those.
Matt, any final comment before we move on?
Yeah, I completely agree with Lee. I think, one of the questions that comes up is when we move a new therapy into our practice, in this case CDK4/6 inhibitors, what are the question comes up, what are the drivers of in this case, of progression, molecular progression? One of the things that we know across all CDK4/6 inhibitors is that we see these RB mutations. And so we know that in general these RB mutations clearly help us so that we could say, well, gee, if you were at least entertaining CDK4 after CDK4, you'd probably say, let's not do that in that situation. What we don't know is, does a RB mutation, let's say in the presence of a PIK3CA mutation, mean anything in terms of response? I'm not using that information for making a decision about, let's say, alpelisib in this situation. And so, but I agree with Lee. I think the more data we get, we're going to see emerging biomarkers, and that's going to affect how we think about our therapies.
So I think what we're all trying to say is we don't necessarily do that on a routine basis at every time of progression, and that's not necessarily going to help us guide every therapy, but there are a few things we have learned that we do apply on an individual patient. For example, RB1 mutations, lack of benefit that we might see from CDK4/6, and so on and so forth. So Lee, if you could walk us through this data for targeting the PI3K pathway.
Yeah, so the first drug we actually had was everolimus, and that was tested quite some time ago now in the pre-CDK4/6 inhibitor in the Bolero-2 study. And everolimus and exemestane is an mTOR inhibitor. Compared to placebo, improved progression-free survival, substantially over doubled the progression-free survival. And it's interesting now to look back at the everolimus data, which was a very modest progression-free survival. We've recapitulated that in the more modern era, looking at fulvestrant as standard of care in the more recent studies, that it's really monotherapy after first-line therapy. In this case, even before CDK4/6, gives you a very modest benefit here. And then the PRECOG 0102 study showed similar data there, about a doubling, in that case with fulvestrant. And then SOLAR-1, which we referenced before, was a study looking at patients who had hotspot mutations in PIK3CA, done by PCR actually, that fulvestrant and the alpha-specific PI3 kinase inhibitor, alpelisib, finally showed a benefit. And this was the result of a long journey of looking at PI3 kinase inhibitors, many of which were too toxic to actually bring to the clinic. But alpelisib doubled the progression-free survival, as you see here, with compared to fulvestrant alone. And in this particular study, there was only 6% of patients who had prior CDK4/6 inhibitor. So that doesn't really reflect the common situation today. The discontinuation rate was about 25% in alpelisib in this particular study versus only 4%. And the common side effects that we see with this drug, and they're class effects, they're actually on-target effects because of the metabolism and the effect on insulin metabolism from PI3 kinase. So hyperglycemia was seen in over a third of patients, grade 3, and rash and diarrhea were also seen as substantial side effects.
So BILEAV, I think, was the study that looked at patients post CDK4/6 inhibitors, I guess, but not
Right.
a randomized trial, and gave us
Right, and I think we have a slide on that.
Yeah.
So here was BILEAV, which looked at these patients as they are treated today in the modern era with CDK4/6 in the first-line setting. There were 3 cohorts, non-randomized trial, looking at different populations. Cohort A were patients who had immediately had the prior treatment with an AI and CDK4/6, representing most of the situation we deal with today. And in that particular setting, a fairly large trial, over 120 patients, the median progression-free survival was 7.3 months, and did not compare. It was not a randomized trial, but knowing what we do now from multiple fulvestrant, that's substantially better. Cohort B was CDK4/6 and fulvestrant as immediate prior therapy. This represents the situation we see for patients who get first-line fulvestrant, whether they had an ESR1 mutation detected or whether they had primary endocrine resistance and so therefore got that combination. In that case, they switched to the AI, letrozole, alpelisib, slightly less progression-free survival, but 5.7 months. Still probably clinically reasonable. And cohort C were patients who received either chemotherapy or endocrine therapy as immediate prior therapy, fulvestrant, alpelisib, 5.6-month progression-free survival as well.
Thank you.
So a couple of things to summarize SOLAR-1 and the BILEAV trials. If you look at the response rates were higher in SOLAR-1 with fulvestrant, alpelisib, compared to those patients who had had previous CDK4/6 inhibitors in cohorts A and B. Not too surprising. Clinical benefit rates were also better for SOLAR-1, but substantial in cohort A and B of BILEAV. And it's interesting that if you looked at a waterfall plot, they're not too dissimilar in terms of the decrease in best percent change from baseline. The other interesting thing is, as we learned how to use alpelisib better, the relative dose intensity went up from SOLAR-1 to BILEAV almost 90%. And also, correspondingly, the adverse reactions leading to discontinuation went down with better management and learning how to use alpelisib, which took some learning, but those of us who have experience with it now understand how to manage the hyperglycemia and the rash. And you can see that the grade 3 or the AE leading to discontinuation rate from hyperglycemia was quite low in BILEAV. We also saw some data from San Antonio with metformin, which improves the hyperglycemia with alpelisib. So I think we're learning how to manage this drug better, and that will lead to longer time on therapy and better results for patients with a PIK3CA mutation.
Thank you. And then this is just the double PIK3CA mutations or multiple PIK3CA mutations, as you were talking to us about, where you can see up to about 10 to 11% of our patients can carry these more than one PIK3CA mutation in the tumor, and seen more in breast and GYN tumors. And maybe if you could just walk us through this data on the right about what their impact might be, I think that would be great.
Yeah, and that was from tasilicib, the Sandpiper study, which was a drug that, although it showed clinical benefit, was too toxic to bring to the clinic.
Right,
So-
right. So I think you do see that if you have more alterations, potentially you might be more addicted, the tumor might be more addicted to the pathway, and potentially the responses are higher. So this is one thing. So I'm sure you're going to give the drug with one alteration, with two, there is no reason you should not consider giving it, as what we're trying to learn from this. And then we did learn about targeting different nodes. So we started off the bottom of the pathway with mTOR inhibition as proof of concept from Bolero, and then we targeted the PI3K pathway, and is AKT an important node as well? And maybe Ruta, you can walk us through the data on Capivasertib in ER-positive breast cancer.
Sure. So this is a phase 2 trial. These were patients, we know that more than 50% of patients with ER-positive metastatic breast cancers have activated PI3 kinase, AKT, PTEN pathways. And so that's what really brought Capivasertib into the trial here. It's a potent and selective inhibitor of all three isoforms of AKT. And in the phase 2 Factian trial, the addition of Capivasertib to fulvestrant doubled the median PFS. And you can see that in the curves on the right. So the PFS was 10.3 compared to 4.8 months with a hazard ratio of 0.58. We did see the updated efficacy data after a median of 60 months of follow-up. Expanded NGS testing was used to identify AKT1 E17K mutations, additional activating PIK3CA mutations, and PTEN alterations, which predicted to result in loss of function. And these alterations were found in 54% of the intent to treat population versus 42% using the original methods. You can see that the PFS and OS data indicated that Capivasertib mainly benefited the pathway altered subgroups. So that's really where we saw the greatest benefit. And you can see that in the curves on the right here. So that brings us to the phase 3 Capitello trial. These were patients with hormone receptor positive, HER2 negative advanced breast cancer. They had recurred or progressed while on or within 12 months of the end of adjuvant AI, or progressed while on prior AI for advanced breast cancer. 2 or fewer lines of prior endocrine therapy for advanced breast cancer, 1 or less lines of prior chemotherapy. Prior CDK4/6 inhibitors were allowed. No prior SERDs, mTOR inhibitors, PI3 kinase inhibitors, or AKT inhibitors were allowed. As we know of the toxicity of hyperglycemia, the hemoglobin A1C had to be less than 8%, and diabetes not requiring insulin was allowed on the tumor. Formalin fixed paraffin embedded tumor sample from the primary or recurrent cancer had to be available for retrospective testing. These patients were randomized to either Capivasertib with fulvestrant or placebo with fulvestrant, with dual primary endpoints of progression-free survival by investigator assessment for overall and in the AKT pathway altered tumors. Key secondary endpoints were overall survival and objective response rates. And here at the bottom of the slide, you can just see the patient population, and to point out here that 69% of patients in the overall population had received prior CDK4/6 inhibitors. So this is more representative of the patient population we would see today than some of the prior targeted therapy trials we had seen. And here you can see the AKT pathway alterations. Any AKT pathway alteration was seen in 43% of patients in the Capivasertib arm, 38% in the placebo arm. You can see the percentage of PIK3CA mutations, AKT1, and PTEN mutations. Non-altered patients were 56% of the Capivasertib group and 62% of the placebo group. For the dual primary endpoints of investigator PFS in the overall population and in the AKT pathway altered population, you can see the Kaplan-Meier curves here. For the overall population, the median PFS was improved from 3.6 to 7.2 months with an adjusted hazard ratio of 0.6. And for those patients with AKT pathway altered alterations, it was 3.1 months compared to 7.3 months. So significant benefits in both populations, slightly better potentially for the AKT pathway altered population. What about toxicities and discontinuation? There was a 13% discontinuation rate in this trial and 20% dose reduction. The most common adverse events were diarrhea, rash, nausea, and fatigue. Grade 3 diarrhea was seen in 9% of patients, grade 3 rash in 12%, and grade 3 hyperglycemia in 2.3% of patients. For the exploratory analysis of investigator-assessed PFS in the non-altered population, including those with unknown, you can see that there was still a significant improvement in median PFS from 3.7 to 7.2 months with a hazard ratio of 0.7.
So just a brief comment before we move on to the next part of this variation in this question. In the interest of time, maybe a brief response. Based on these data, say if Capivasertib gets approved, how are you thinking about these data versus the alpelisib data for our patients, or for this particular case, if you will, who has a PIK3CA mutation? Matt, Reshma, any thoughts about how you're thinking about these data sets?
So I have to say I'm very impressed by the Capitello data. I think there's a couple things that are important. One of them is that obviously the toxicity in terms of the hyperglycemia appears to be less. You know, the question though, of course, is in the era that Lee said, you know, we now sort of know how to manage some of these toxicities from alpelisib. And so, you know, some of that may be a little bit less of an issue than perhaps a couple of years ago. I am interested in this whole group of patients that are non-altered. You know, years ago, Todd Miller, when he was in Carlos Artiega lab, had a paper in JCI that showed that if you take, you know, an aromatase inhibitor, or if you take an MCF7 cell line or another cell line and you estrogen deprive it long enough, you activate the AKT pathway. And so, you know, is this non-altered group of patients sort of getting activation of the pathway independent of, you know, the you know, a mutation? So I think it's really quite interesting. I think we're going to have good choices, and I think it's going to be even more complex because many of you know that some of these newer drugs that are coming forward, Kamal, you know about this, and we have a study, you have a study utilizing these allosteric inhibitors of PI3 kinase that appear to really, you know, target the pathway, but without all the, you know, the toxicity. So you don't have the ATP competitive effects where you get all the other side effects. So it's an interesting time, and we're gonna learn how to manage these. And I think the good news for patients is there's going to be options.
That's right. Reshma?
Yeah, I would just add that I think, you know, this was really interesting from that non-altered population as well to see that activity. But from a practical standpoint, in terms of the toxicities of alpelisib, I agree, we've definitely gotten better about managing it, but it's still tough, right? Patients have to start on metformin commonly. They have to deal with dose holds, delays related to rash and hyperglycemia and finger sticks. It's a tough drug. So having an agent that has activity with a better tolerability profile, I think, is really appealing.
So looking forward to all of this and offering our patients all these options. So now let's change the variation on this case. So we're not thinking about PIK3CA mutations, but instead, now on NGS, we showed that the tumor is now detecting an ESR1 D538G, which is 12% variant allele frequency. And what if this was progression in the bones after 24 months with this ESR1 mutation? So does duration of CDK4/6 inhibitor matter? Does this ESR1 mutation finding matter? And how would you think about treating a patient post CDK4/6 inhibitor? Matt, maybe I'll ask you to walk through these data.
Sure. So this is I can't really say it's emerging because it has been emerging for a while, but certainly these ESR1 mutations really were one of the amazing advances in the setting of NGS. Partly because, of course, the fact that people had looked at for the presence of these mutations in hormone receptor naive or newly diagnosed breast cancer, and they're rare as hen's teeth there. So people really felt like these probably weren't an important entity until all of a sudden, lo and behold, people started doing NGS in the metastatic setting and saw frequencies that were much higher. So as this, in the summary here, they're pretty rare in newly diagnosed patients, but they tend to be much higher. They're, as Komal said, they're subclonal, they're selected out in the presence of hormonal therapy, most commonly in the setting of aromatase inhibitors. They are a cause of endocrine resistance. They've also been shown to be a poor prognostic factor as well. So just simply having them has been associated with a worse prognosis. If you try to go on in the setting of, let's say, a non-steroidal AI and use a steroidal AI such as exemestane, they predict poor response. And even though fulvestrant, we think of as a SERD as a drug that potentially would have value in the presence of these ESR1 mutations, as nicely said, fulvestrant has some limitations, and we'll talk about that here. So here are the oral SERDs, and this is what we're all so excited about, which is basically we have fulvestrant, we know it's a good drug, it does what we think is very important, which is targeting the estrogen receptor for degradation. But of course, the limitation is having to come into the clinic for an intramuscular injection twice during that first month and then monthly thereafter. And most patients tell us over and over again, please give me a pill that I can take so I don't have to come into the clinic, if possible. And so these are the oral SERDs that have been developed, elacestrant. Of course, we're all familiar with these data. It's been published. We've had some updates. We'll talk about that. We have the data from AMIRA-3. We have the data from Accelera with giredestrant, Serena-2, and EMBER-3. So one of the things that you can see is that it appears that not all of these oral SERDs are created equal. So for example, if you look at amcenestrant in the AMIRA-3, this was presented, an update at the ESMO meeting. It did not meet its primary endpoint. Similarly, giredestrant did not meet its primary endpoint either, although still the development of that particular drug is ongoing. Capivasertib is the oral SERD that's been developed by AstraZeneca. This was presented at San Antonio. And really, thus far, this has been the SERD that I think has showed the most impressive data, an improvement in PFS from 3.7 to 7.2 months. And of course, the EMBER-3 data with imlunestrant, we're really awaiting result from this. This is Lilly's drug, and we don't have those randomized data as of yet. So here's the PFS data for elacestrant versus fulvestrant. You've all seen this in all patients and in tumors harboring mutant ESR1. I would say this, and this is just an aside, Lee mentioned this earlier with the SOLAR-1 data, 5% or so, or a relatively small number of patients in the SOLAR-1 had received prior CDK4/6 inhibitors. But we had the first hint of something weird going on, and that is what we saw was that fulvestrant monotherapy in that SOLAR-1 post-CDK4/6 had a median PFS of 2 months. And we all thought, what's going on? Is that really true? And the answer is, it is true. So here's the data with elacestrant versus fulvestrant. Everybody had received a prior CDK4/6 inhibitor. Although, again, you see a significant improvement in median PFS from about, with the fulvestrant arm, you can see that fulvestrant really had a very poor PFS of 1.9 months. Elacestrant did improve that, but in those patients that had potentially some addiction to the ER pathway, that is a mutant ESR1, now you're beginning to see some improvements here that I think approach clinical significance. So improvement from 1.87 to 3.78 months. Go on to the next slide. So this was the presentation at San Antonio from Dr. Kaklamani, looking at the whole issue of duration of prior CDK4/6 inhibitor. And if you're an oncologist and you've been around for a long time, this is what we know in practice. That is, if you're on a therapy and you do well for it a long time, it predicts for better response for the subsequent therapies. But we needed to see it, I think, in the setting of this trial, and here we saw it indeed. And that is, if you had relatively rapid progression on your CDK4/6 inhibitor, you don't do well at all with monotherapy. And I think this really cements the fact that we should not be giving our patient endocrine monotherapy if they have a rapid progression on a CDK4/6 inhibitor. But you can see all the way out here to the 18-month rate, at least 18 months, where you begin to see these larger differences, and especially in the ESR1 mutated. I think you have a slide on that if you keep going here. Yeah, in the ESR1 mutant, where you begin to see even these larger differences. And so I think what will, of course, the first question is, will this drug be FDA approved? I think, as I've heard, this is going to be reviewed in February, and so I think it would be an advance for our patients to have access to this drug. And again, there's certain subgroups here of patients that appear to do better with elacestrant, and that is proven here by this particular presentation. I think we have to be careful a little bit. This is not a planned, this was not put into the protocol, but again, I think this is something that we certainly do think about, and we see this with other drugs as well. This actually now is a slide just looking at the PATA-1 data. The PATA-1 data, of course, was taking patients who have a diagnosis of ER-positive, HER2-negative breast cancer who are receiving therapy in the first-line setting with palbociclib and an AI, and screening those patients for the presence of a new ESR1 mutation, this subclonal, this, the development of an alteration. And the question in the PATA-1 was, well, should we wait for patients to develop symptomatic disease and then change therapy? Or might it make sense actually if you could actually detect that ESR1 clone early to switch therapy and then in so doing prevent recurrence? And I think that what this study showed, of course, was that first of all, you had to screen a lot of patients to identify the patients. You can see they screened 1,000 patients to identify 242 patients then to randomize. But that being said, this was a relatively, in my mind, impressive improvement of nearly 6 months 5 months, with a hazard ratio of 0.63. I think we all saw that and felt like this is probably not ready for standard of care, and this is where the SERENA-6 trial, I think, is really so important. This is actually taking really almost the same design, taking patients in that first-line setting, screening patients for the presence of an ESR1 mutation, and then when present, randomizing them to, in this case, continuing on an AI plus CDK4/6 inhibitor plus versus switching to Capivasertib. So with that in mind, we talk a little bit about what is the best approach if you have an ESR1 mutation. Can we develop a better SERM? So these are the data with lasofoxifene and specifically the binding affinity for the Y537S mutation. So lasofoxifene, if you recall, is a SERM that was developed back in the 1990s and actually is utilized in Europe in patients based on the PEARL data. It was not approved in the US. But more recently, in the last few years, has been studied at higher doses and higher concentrations based on the fact that preclinically it was shown to be highly effective for not only targeting tumors with the ESR1 mutation, but actually leading to growth inhibition, effects to reduce metastases, et cetera. So here what you're looking at is a variety of different SERMs, and here you're seeing specifically against the Y537S mutation, the KD for lasofoxifene is actually quite good, suggesting that this might be a drug to specifically target this alteration. These are data we presented at ESMO looking at the LANE-1 clinical trial where patients were randomized to either lasofoxifene versus fulvestrant. Patients in this study had to be eligible if they had progressed on an AI plus CDK4/6 inhibitor. This was a trial of a small signal-seeking study, randomized phase 2. And there was a signal here. This was not statistically significant, but the hazard ratio was 0.699. There was a signal here in terms of median PFS as well as overall response rates. Here you can see the response rates, and on the on the left-hand side, clinical benefit rate. The data that I think are even more provocative are the LANE-2 trial, LANE-2 data, combining lasofoxifene with abemaciclib in patients who have ESR1 mutations. This, again, of course, really same idea. You take patients who have progressed on palbociclib or ribociclib, and they're treated with lasofoxifene and abemaciclib. Here you can see a response rate that I think approaches what you might expect with a drug like trastuzumab deruxtecan. Response rate of 50%, a median time to response of greater than 160 days. You're seeing PFS that are well beyond 6 months. This is, again, a small study, but it's leading to a phase 3 randomized FDA registration trial taking patients who have progressed on a CDK4/6 inhibitor, either ribociclib or palbociclib, randomizing them if they have an ESR1 mutation to lasofoxifene plus abemaciclib versus fulvestrant plus abemaciclib, and that study is planned to activate later this year. Safety, this is a relatively boring drug in terms of its safety profile. There really wasn't much going on, at least in ELAINE 1. In ELAINE 2, because you combined it with abemaciclib, there was some DVTs that were seen, or thromboembolism, and that's something that's going to have to be looked at. This here is just some retrospective data, again, looking at the question or the role of using CDK4/6 inhibitor beyond progression. What we've seen, I think, with the drug abemaciclib is that there is evidence for activity post-palbociclib. You can see there Seth Wander in JNCCN about a year or two ago had a publication, PFS of around 5 months, overall survival of 17 months. And then Komal, some of your data from Memorial, again, suggesting that there may be some benefit, especially utilizing different CDK4/6 inhibitors. So if we go on to the next slide, this is here, the MAINTAIN trial. This was presented at ASCO this last year. And this study looked at patients who had progressed on an endocrine therapy and CDK4/6 inhibitor, less than 1 line of chemotherapy. Patients were randomized to with a placebo control, which makes this a really, I think, a very good design to switch endocrine therapy that was the arm 2 versus ribociclib, that is moved from, in this case, mostly palbociclib to ribociclib plus switching endocrine therapy. You'll see there were a few patients that actually had ribociclib in the first-line setting, but the bottom line is that in this study, there was a statistically significant improvement in median PFS. You can see from 2.7 up to 5.2 months. PFS rates at 6 months were also better in 12 months. This, of course, is the PACE trial, and this was just presented at San Antonio. We were awaiting these data because we thought, well, and many of us, by the way, I've been doing occasionally this in my practice as well. If a patient has been on a CDK4/6 inhibitor for a prolonged period of time, I've swapped out the endocrine therapy and simply kept them on palbociclib. But we didn't have randomized data, and of course this is why we do randomized clinical trials. You can see here patients in this study progressing on a CDK4/6 inhibitor with endocrine therapy, and they had to have greater than 6 months stable disease on their prior regimen, so they didn't allow these sort of rapid progressive patients. Were randomized to fulvestrant alone, fulvestrant plus palbociclib, and then a third arm, very provocatively, avelumab. And this is interesting, of course, based on the data that would suggest that this combination actually had a fair amount of preclinical activity, and it has been studied now in a number of variety of settings. But the bottom line here is you can see that there was no improvement in PFS for adding or continuing, in this case, palbociclib along with the endocrine therapy. You can see median PFS of 4.8 months versus 4.6 months. There was a suggestion that adding avelumab did improve the outcomes. You can see the hazard ratio of 0.75. This didn't meet statistical significance, and also in terms of overall survival as well. So I think what we can take from this is certainly provocative. It's hypothesis generating. I don't think we should be doing this in our clinic ever at this time based on some of the prior data with Pembro and other immune checkpoint inhibitors. Although I would say with this particular drug, the toxicities seem to be less perhaps notable than in some of the prior studies, but again, this is not yet standard of care.
So do you routinely do change a CDK4/6 inhibitor and continue another CDK4/6 inhibitor, continue the same endocrine partner, or change the endocrine partner, or both in your practice today?
Yeah, so I think where this does come up, and thinking a little bit about the elacestrant data, is this scenario where we have a patient that's been on a CDK4/6 inhibitor for 3 or 4 years, and they have one site of progression. You know, I think that's where, you know, many of us would like to be able to continue on with therapy. I think based on the data right now, I would feel quite comfortable in that situation of actually continuing on with endocrine therapy or switching, let's say if they were an AI, switching to fulvestrant and moving to ribociclib. Again, this is not yet standard of care. And especially where I think about this, I had a patient just recently where bone-only disease, and I was looking for, an alteration based on a Garden 360, and I couldn't find one. And so we see this, right? And there's not an alteration that we can see, and so I think there are probably a subset of patients where this might make sense. But clearly right now, the PACE trial would suggest we shouldn't be routinely doing this with palbociclib.
That's right. So last variation before we close out for the session, if there was a ERBB2 mutation, in this case it was the S310F mutation, and a PIK3CA mutation, how would you then think about treating this patient? And then what if the germline testing revealed BRCA1 and 2 mutations? Maybe Lee and Ruta, I'll have you address both of these respectively.
Okay, so HER2 mutations are actually not that rare in HR-positive, HER2-negative breast cancer. So in about 8% overall, and this is probably a mutation that occurs in the face of therapy as an adaptive mutation, not one that we tend to see early on in primary breast cancer. One important point to keep in mind, though, is that for invasive lobular carcinoma, it's more common. So as many as 15% of ILC will have a HER2 mutation that is potentially targetable. And the SUMMIT trial looked at this in multiple cohorts for patients that were HR-positive, HER2-negative, but had an ERBB2 mutation. And you can see the cohorts listed there. It was first studied actually in the early SUMMIT trial as single-agent neratinib, which has activity against ERBB2 mutations. You can see the response rate to even monotherapy was 17%. And then dual therapy and then tritherapy with trastuzumab and fulvestrant based on preclinical models that suggested that that would be the most effective. And the most recent data you see in the bottom table that patients receiving neratinib, fulvestrant, and trastuzumab with an ERBB2 mutation have a 35% response rate and progression-free survival of 8 months with a long duration of response. So this is early data, it's phase 2 data, but it is something to think about in patients that you're getting NGS on in late-line disease before chemotherapy to consider this combination. And there are other trials that are looking at this now, so tucatinib and trastuzumab as part of a basket study that includes ERBB2 mutations in other disease states, but also includes breast cancer. And then there are newer agents that are being tested as well that are not yet approved, and also trastuzumab deruxtecan in the Destiny Pan-Tumor 01, so similar basket study trial for patients who have an ERBB2 mutation are being evaluated.
Thank you, Lee.
Can I ask you just a quick question? So what would everybody do if you had that the HER2 mutation and the PIK3CA mutation?
Yeah. Anybody want to comment? Reshma, Lee, what would you do? Would you try and look for neratinib for that patient? Would you offer them alpelisib first?
Oh, no, I would, I mean, the data is not strong enough to offer it first. I would do it as secondary. And the one thing that at least I'm not aware of is whether the PI3 kinase mutation actually influences the activity on a HER2 mutation as it does in HER2 amplified negatively. So it's something to think about.
Yeah, I would probably use alpelisib also for it.
Yeah.
I'll take this liberty to call upon Cynthia, who's in the audience and not on the panel here, but has done a lot of work with HER2 mutations and PIK3CA mutations. And what would you think about, and could you tell us that?
Yes, I think in the preclinical modeling, mutations in PIK3CA could confer some resistance to the TKIs like neratinib to the HER2 mutated breast cancers. But in our mTOR trial, even in your SUMMIT trial, I think patients with PIK3CA mutations still benefited. Not all patients, but maybe a slight lower response rate when we look at the data, like the SUMMIT trial. And also we've seen in patients who progressed on the triplets or the TKI plus trastuzumab plus fulvestrant, even in the SUMMIT trial, that when you look at resistant mechanisms, you can see there are new PIK3CA mutations that were emerging, that was not present previously. And interestingly, one of the patients was treated at our center, and that patient acquired PIK3CA mutation exactly. Seems to be a subclonal, but when she gotten the alpelisib, after progression on the SUMMIT trial, she had a great response as well. So I think it is a potential resistant mechanism, but does not exclude me to try the TKIs, neratinib, trastuzumab, fulvestrant triplets. I mean, I hope that we have this eventually in the clinic.
Okay, thank you. And Ruta, maybe this last slide on PARP inhibitors, and we can close.
Sure, so just to round out the discussion on targeted therapy, we know that we have 2 PARP inhibitors that are FDA approved for germline BRCA mutation carriers who have metastatic breast cancer. So the Olympiad trial showed the benefit of olaparib compared to treatment of physician's choice with an improvement in progression-free survival, and the treatment of physician's choice here were a variety of chemotherapies. Similarly, the EMBRACA trial looked at talazoparib in this same setting, comparing talazoparib compared to treatment of physician's choice of chemotherapy. And again, across all of the subgroups that were looked at showed a benefit to talazoparib.
Thank you. So to wrap up today's session, and there's so much more in ER-positive breast cancer that we can keep talking about, and I recognize that we're so over time, and I apologize for that. But to kind of wrap up, I think for a newly diagnosed HR-positive, HER2-negative breast cancer patients, I think we are thinking about sequential endocrine-based targeted therapies still. We use about 1 to 3 lines of sequential therapies. I think CDK4/6 inhibitors are the mainstay in the first or second line. We do have various therapies after CDK4/6. We really don't understand necessarily the entire optimal way of sequencing them. But today in clinic, if we have a mutation in the PIK3CA gene, we are offering them a PI3K inhibitor. That might change with Capivasertib getting approved, as we were discussing. We have LSS-trant that might get approved, and maybe there might be appropriate patients for either LSS-trant alone or SERDs alone or SERD combinations that are being evaluated. Certainly PARP inhibitors for the 3 to 5% that have BRCA mutations. We didn't talk about NTRK fusions, but they can be possible very rarely, and we have NTRK inhibitors approved. We have pembrolizumab approved as well for our high tumor mutational burden patients. Following endocrine therapies, we do think about sequential single-agent chemotherapy for most patients unless there's a visceral crisis. If they have had 1 line of chemotherapy, no more than 2, we discussed the DESTINY-04 data in the previous sessions today, and there's data for trastuzumab deruxtecan. What we did not discuss today was data on sacituzumab that was really presented from the TROPiCS-02 trial. So this is a TROP2-directed antibody-drug conjugate. Majority of the patients had progressed on CDK4/6, median 3 prior lines of chemotherapy in the metastatic setting, so really pre-treated patients. And despite that, we did see an overall survival benefit about 3 months, 14.4 months for patients receiving sacituzumab. It's under FDA review, but already NCCN endorsed. And today in clinic, for those always HER2-0 patients, until the whole HER2 testing that we discussed evolves, we would think about sacituzumab, or for a very pre-treated patient, we think about sacituzumab. Thank you all for sticking along despite the lunch break.